Today, I'm going to discuss with you whether it's possible to provide the art of personalized cell therapy in the era of artificial intelligence and increasing computer-driven care. I'm sure you all have been enrolled in working with electronic health records. It is implemented in many countries, and in those countries where it's not yet fully implemented, it is in the process of being implemented. And I think all of us who have had to go through that process have experienced some issues about the impact that process has on our practice and impact that that practice has on our patients. Just to give you a little background, my name is Finn B. Petersen. I consider myself a second generation cell therapy physician, starting doing bone marrow transplants back in the 1970s, went to the Hutchinson Center in Seattle in the 1980s, and had as my mentors Dean Buckner and Don Thomas, which many view as the true pioneers of cell therapy. So I feel I have been trained well. I have had the pleasure of starting 5 cell therapy programs in my career in different parts of the US as well as in Denmark. And so now that I am retired, I can look back on 40 to 50 years of having immersed myself into cell therapy, including having to transition my practice into the computer-driven era. Before we get into it, let's talk a little about what the art of personalized cell therapy is. Obviously, there's not much therapy on this, not much literature on this subject alone, but there are some on the practice of the art of oncology. ASCO, over the last couple of years, have done a number of activities to try and foster a discussion about the art of oncology. They have done that through their ASCO post as well as JCO, and they have done it through their podcast. What you can extract from the multiple articles from multiple stakeholders like patients, physicians, ancillary service nurses, etc., is that it's clear that there are some helpful talents to have when practicing the art of cell therapy. For example, knowing the state of the art of general medicine, medical science, and cell therapy is clearly an advantage. Having resilient curiosity and persistence in pursuing the best explanations for an individual patient's unique and often complex challenges obviously is a good talent to have. Understanding the patient's story, the whole story, and what that means for how to apply or modify the science is helpful. Having the ability to understand and genuinely empathize with any patient, that is helpful. Having excellent communication skills and the ability to make a patient make a truly informed choice, that is helpful. And of choices presented to the patient, always respect his or her choice, even if it is not the practitioner's first choice, and work as hard as you can to make that choice successful for the patient as if it had been your first choice. It is worth noting that none of these supportive talents require excellence in computer data entry, computer programming, or computer management. And basically, the art of cell therapy really doesn't have to rely on any computer technology. Then we have to ask, how has it come to be then that the focus on the practice of oncology and cell therapy has become increasingly computer-based at an increasing pace since 2010. And what impact does this computerization have on patients and physicians, as well as nurses and other ancillary services involved in the treatment of our patients? Now, just very briefly, how it came to be in the US, and actually the story is very similar in most other places in the world, usually pushed by the software companies who are giants worldwide and in the US. And they lobbied hard, some would say almost bribed, the legislature in the US to pass what was called the High-Tech Act, mandating healthcare providers to convert all medical charge to a digital format in all 50 states back in 2009. And they used carrot and sticks to make that happen. And by 2014, it was completed with not 100%, but near 100% of hospital facilities having EHR, and a majority of private practices and clinics having converted to EHR. In the US, there are three top systems, Epic systems being the largest, having 48% of the market, but covering 87% of patients. The Oracle Cerner covers 25% and Meditech 14%. There are hundreds of other vendors that are offering EHR software, constituting 13%. And obviously, with that many different software products, many of them with proprietary information and not communicating, there are some problems that needs to be addressed in making this a truly transparent nationwide system. EU has passed similar edicts about having systems that the different EU countries can communicate patient information through. They also, with this computerization, has as a goal that all EU citizens can get health anywhere, and that those that provide that health can get the information from other countries through the systems. Now, the selling point from that Epic and Cerner and the other software manufacturers made and sold to the politicians and some physicians is that interoperability makes it easy for clinicians everywhere to access all information, improving quality of care and communication. However, the reality is 2023 is that no interoperability exists between the different EHR systems, but does exist within the individual systems, so that institutions that have Epic, they can communicate pretty transparently with information that has been generated in another institution, but Epic cannot communicate with Cerner and vice versa. And so if a patient needs care and the providers need quick information in an Epic-driven system, and the patient had most of the information generated in a Cerner system, it is usually not possible in a timely way to get that information, which was one of the main selling points of the EHR system. The promise was made that it would eliminate medical errors, but the truth is that the jury is still out as what the net effect has been, because while there definitely has been some decrease in some of the medical errors, there has been a documented increase in EHR-related errors, and whether they negate each other or whether there's more of one or the other, that has not been possible to tease out at this point. The promise was made that it would improve patient engagement, but the reality today is that clinicians, in particular in the US, spend more time entering data than with patients. While the time clinicians have to cut away from patients to satisfy the computer requirements have been documented to be higher in the US, it's definitely also a problem in Europe and in other parts of the world that are implementing these systems. The promise was made that there would be better and more accurate communication. However, the reality as of 2023 is that there are prevalent, erroneous, and out-of-place information from aggregate and data entry errors, most from cut and pasting. There's been a study where patients reviewed their EHR notes from a visit, and with up to 40% of the patients detecting major errors that could have impact on their care, and with the correction of these errors not always being easy. There was a promise of enhanced privacy and security, but in the US alone, and I'm not totally familiar with what the situation is in the rest of the world, but I suspect it's similar, there has been 14 massive data breaches since 2011, where a total of 14 million US patients have had their medical record either partially or completely hacked and put into the dark web for sale, with implications still not being completely clear. Now, after the EHR was implemented in some of the larger hospitals and organizations, anthropologists actually did observational study to find how it impacted the patient, physician and patient-nurse relationship. Linda Hunt and her co-workers had a very interesting paper. She's an anthropologist that was titled Electronic Health Records and the Disappearing Patients. And in that study, they found that the EHRs, none of the EHRs are really structured to prioritize patients, but to prioritize political and cooperative stakeholders, most often not relevant to clinical care. They concluded that we argue that the EHR enforces the centrality of market principles in clinical medicine, redefining the clinician's role to be less of a medical expert and more of an administrative bureaucrat, and transforming the patient into a digital entity with standardized conditions, treatments, and goals without a personal narrative. And again, those of us who have been through the transition from old-fashioned patient charts to electronic medical records certainly should be able to recognize some truth in that conclusion. And what about the patients? Well, we have known for a long time, going back to the 1990s, what care patients desire. The Picker Institute, which is a patient protection institute, quite highly considered both in Europe and the US, defined the 8 principles of person-centered care. None of this should come as any surprise. First, fast access to reliable healthcare advice. Second, effective treatment delivered by trusted professionals. Thirdly, continuity of care and smooth transitions. Fourthly, involvement of support for family and caregivers. 5, clear information, communication, and support for self-care. And 6, involvement in decision and respect for preferences. And 7, emotional support, empathy, and respect. And 8, attention to physical and environmental needs. And again, just like the talents that are required for providing the art of medicine, the art of oncology, the art of cell therapy, none of those principles require medical computer technology to be implemented. For the patients, the promise of mandated EHRs included that all providers will have instant access to your medical record no matter where you show up, which is beneficial in emergencies. And while that is unquestionable, as we discussed before, this is time consuming and often not possible and costly to the patient and takes weeks often to achieve unless within the same EHR system. That is true in the US, and that is true certainly in Europe, where there are just as many different EHR systems used by each individual country. The patient was promised there would be a decrease in errors, but as we talked about, the patients who do read their EMR, and this is a select group of usually very computer savvy and well-educated patients, responded that they found mistakes and that 40% of those mistakes were serious. They were promised, the patients, improved patient engagement with better efficacy and time management, but multiple studies have shown that clinicians spend more time entering data and writing electronic records and notes than with patients. Also, the software is often difficult for patients to access and require some degree of computer literacy. The patient portals with Cerner and Epic and others called MyHealth, MyChart, eHealth, Easy Access, and so forth. Through that, the patient is expected to make appointments and check appointments, to make medication refills, to communicate with the provider, to review so-called after-visit summaries, and to review if they are started on a new medication procedure, and other boilerplate long explanations of printouts. And through these portals, the patient also have real-time access to laboratory results, imaging, pathology results, and all notes filed in the patient's record, often viewing them before at least the results before the provider can, and thus not necessarily knowing what they all mean. Now, the medication procedure and other boilerplate long explanation printouts is provided by a central company or central companies that provide generic explanation, pretty much printouts of FDA-approved writings, so often very detailed and ream after ream, which we know many patients don't bother reading. Instead, they go on their computer and social media and look it up in a search engine if we're lucky, or on Reddit or in Instagram or other places if we are not lucky. An interesting paper was written by a well, let me say that the promise of mandated ESR was that patients will have real-time access to all tests and exams provided through a portal. And the U.S. Office for the National Coordinator for Health ITs, ONC, made it clear a few years ago that providers can no longer delay or block or change the release of electronic health information to patients, including the patient's laboratory, pathology, and imaging results, as well as the notes. Um, a physician published in JAMA Oncology in 2023 a little op-ed called "You've Got Mail: Receiving Bad News Through a Patient Portal." He had himself a cancer. He had been to a test that in which was a CT scan, and he on Friday afternoon read that CT scan and pretty much knew that he had relapsed, but also knew that it was written in a way that you had to be a physician to know that you had relapsed, with it being unclear how an unsophisticated, medically unsophisticated patient would read a report like that. And I'm thinking for our own area, a patient who has a bone marrow done on Thursday, and then a preliminary report is being posted and accessed by the patient Friday afternoon, saying hypercellular bone marrow with 15% blast. The patient is post-transplant, some regenerative cells, but cannot rule out a relapse in the setting of post-bone marrow transplant for AML. Immunohistochemical flow cytometry and cytogenetic studies are pending. So what would a patient who is not a hematologist or a physician think about reading a report by that? It's Friday afternoon. His or her provider is not readily available. Yes, you can get an on-call person, but they usually would not necessarily respond appropriately or be too busy to take these and refer the patient to call Monday. So the patient goes on Google, and if we put in hypercellular bone marrow with 15% blast, well, it's very clear that the patient then can see that he or she has probably relapsed, even though we all know that this could very well just be regenerative changes and not be a relapse. But we put the patient through a weekend of grief and agony from thinking that they indeed have relapsed. So, with that said, how computer literate are our patients? Well, we do know a little about that, even though the data is not totally current. The US government, the US Department of Education, published in May of 2018 a description of US adults who are not digitally literate. In that publication, they compared the literacy in the United States to other countries. And as you can see on this graph, which compare mostly developed countries in Europe, Asia, and the US. The lowest rate of computer illiteracy was in the Netherlands and Nordic countries. Great Britain, United States, Germany were somewhere in the middle, with up to 17% of patients being illiterate. And it went as high as 50% of patients being illiterate, completely computer illiterate, in Poland. Now, this is data from 2012, and one has to assume that it has improved since then. But it is clear that either for age reason or for mental capacity reason, a substantial proportion of our patients are not what we would call computer literate. And we know that it is age related. Here you see this is again on US patient, the percentage of patients who are computer literate in the yellow orange, and computer literate and computer illiterate are the blue boxes. And you can see that the illiteracy is the lowest between age 16 and 24, not surprising. And then it increases, and one can predict that this curve will continue to increase with age beyond 65 years. So decreasing computer literacy is a fact with increasing patient age. We know that 35% of people by age 90 years have dementia. But even patients who are age 65 and older have dementia. 10% of Americans over age 65 have dementia, and 1 in 3 patients, or 30 some percent of patients over the age of 65, have some degree of cognitive impairment that may impact on their computer literacy. And then we can compare that to the age of the patients that we are treating. We all know AML, NHL, and myeloma are diseases of old people with a median age between 65 and 70 years. And that is reflected in, as our technology has improved, more and more patients undergoing allogeneic transplant for these diseases. The age has increased over time, and between allogeneic and autologous transplant, actually a third of our patients are over the age of 65. And there's no reason to believe, again, as we get better, that this fraction of older patients that will undergo our cell therapy treatment will increase. So with what we at best can call a problematic and increasing complex electronic health record system, and data systems challenging patients and healthcare workers alike, reducing the time they have together, we are now, without further warning, input, or fully understanding the ramifications, being asked to embrace, on top of the challenges we have, integration of artificial intelligence into our EHR and data systems. Epic has already started pioneering integrating artificial intelligence into their EHR software. They recruited an HI guru who previously worked for Epic, Sam Searing, who actually has a very interesting podcast on Epic's health podcast system that I recommend you listen to, because it truly describes a brave new future. And the first thing they are going to do is to implement a generative AI in clinicians in basket. And that will work like an inquiry is sent to the clinician. AI analyzes the message and classifies it. Is it about medication, appointments, test results, or something else? The AI then generates through the chatbox platform of Microsoft a HIPAA-compliant response. And the response, they say, will be reviewed and approved by the clinician before being sent by that clinician. And they are doing that because they admit AI may bring so-called, what they call hallucination, that is return of garbage, into some of the information. And obviously that would be even more disruptive to send out. It is intended to save the clinician for having to go into the patient's record, absorb the information, and write the response. And you can imagine that this is just the tip of the iceberg. And many AI clinical medical technologies are either here or in final phases of testing, such as AI-assisted imaging, AI-driven patient-provider interactions through chatbot nurses and doctors, clinical trial management system, remotely monitored and smart ventilators, clinical data monitoring, surgical planning systems with 3D modeling, interactive surgical system, and AI-assisted EHR, EMR, and much more. Now, if we look at the AI-driven provider interaction through chatbot nurses and doctors, in Great Britain, they already have that in the form of nurses who will take calls from patients requiring certain information, and then through the voice of a nurse, but all AI generated, answer the patient's question. Maybe if I get to give this talk in a year or two, or even shorter time than that, we may have a talk titled Hi Chatbox, call MRN 09457 and tell her with my voice construct about the CAR T cell infusion tomorrow, answer her questions, and write me an H&P to be ready before the infusions. I am not a betting person, but I would maybe make an exception because I would bet that this will be with us within a year or two, or maybe a shorter time than that. So, my question to you, because you will be the ones, and particularly the younger of you will be the one answering this. Is the future a disappearance of the patient-physician relationship, or will it help us provide optimal personalized medicine? Will it be like Linda Hunt and her anthropological group claims that computer technology in clinical medicine is mainly designed to meet institutional and political priorities, turning the patient into a digital entity and the physician into a desk-bound operator? Or will it be like some physicians who are deeply immersed into AI and computerization claims that the use of artificial intelligence methods will have a positive, effective application in personalized medicine? In other words, is there room for the art of cell therapy in a world focused on the state of the art, computer focused medicine? Will we retain those that are healers, artists, and magicians, at least as viewed by the patient, a doctor? Or will we now transition into being pilots, team leaders, and computer gurus? In other words, drone pilots, where the drone is the patient and we have as much interaction with the patient as the drone pilot has with the drone, sometimes never putting eyes on them, everything done through the computer. So let me wrap it up by offering some final words. Uh, I think that based on the talents that I hope we can agree are helpful to the art of cell therapy, that maybe we can define a cell therapy artist, because many of us who were trained in the 70s and 80s and learned from uh, our mentors who also were trained in a time where there were no computer assisted uh, help. Um, I would like to define a cell therapy artist as a clinician who first learns about the uniqueness of a patient by going through all the medical records before the first meeting. Next, the disease leading the patient to the cell therapy clinician. Then combine this knowledge with state-of-the-art cell therapy to communicate to the patient the pros and cons of possible choices. And when a choice has been made by the patient, then for the cell therapy artist to work tireless to make that choice successful, in the process developing a relationship with the patient that facilitates, first and foremost, comfort and, if possible, healing and cure. I take this as what has been my leading light, what I have tried to strive for. It's not possible always to be able to do this, but if keeping it in mind at all times and trying to strive for it, and having the luxury of being given time, because this takes time, then this is what brings about a healing patient-provider relationship, and in my opinion, the highest chance of both comfort healing, and cure. So, how do we maintain the art of cell therapy? Well, it's going to be tough because I learned from the masters. And now, after I became an old, experienced cell therapy, try to teach this to medical students, residents, and fellows. But we are retiring. I retired in March of this year. And we know that we know that my generation, the baby boomers, are retiring in great numbers and are dying out. Furthermore, those of us who are still working, the masters and young oncologists, are all too busy completing every day's work on the computer to spend time together. Uh, Having to give up being able to go home and be with your family versus spending time with your mentor, that is a tough choice that I do not envy anyone having to make. But I think that there are a couple of things one can do, and I recommend doing so if we want to try and retain some part of the art of cell therapy. And that is to become more critical when new mandates and regulations invade the patient-provider relationship. Also, I do recommend practice having consultations with oncology patients without being distracted by a computer. Uh, I have been to my physicians who all too often are sitting behind a computer screen, no eye contact, asking questions, and then trying to find the right box to put the answer in. And then I recommend at least think and talk with colleagues, patients, and administrators about the implications of the unrelenting automation on patients, and if necessary, to recite the Hippocrates, with all of us having taken the Hippocratical oath, as well as Paracelsus, who is the middle-age standard bearer following Hippocrates in how we should conduct ourselves in our relationship with our patients. So my last advice is trying not to make the 5 to 10 minute with your patients impersonal, to make the visit impersonal, with patients sitting behind with you sitting behind a computer monitor and asking computer generated questions while figuring out how to fit the answers into provided boxes. This picture, by the way, is one that I took 2 days ago when I went to my hospital to my annual health visit. And this was where I was asked to sit down, and where the nurse sitting behind these monitors asked me questions. Sitting down made me completely unable to see her, and it was just awkward, but apparently common and something that we all have to expect. And if nothing else, my hope is that this presentation will at least bring some thought about how we can try and do better. And thank you for your attention. That's all I have to say.
Thank you very much, Dr. Petersen, for really beautiful talk, very inspiring. It's clearly a new topic that we have never addressed as part of the educational activities for the Academy. And I'm very glad, and we are very grateful that you accepted to deliver this talk to us. We will have now a few minutes for some discussion, and obviously also questions from our live audience. And I'm very glad to be joined today also for this Q&A session by Professor Didier Blaise, who is obviously known to all of you, active member of the ICH, but also a very well-known, famous transplanter who, like Dr. Petersen, dedicated more than 3 decades to caring for these patients. So thank you, Didier, for joining us, and please don't hesitate to jump in. So my first question to you, Finn, is very simple. I think you have made the diagnosis. It's clear. The question is about what are the solutions? Because it's like, someone is telling me that my smartphone is annoying me. It's ringing, blipping in the evening, and it's hurting my um, sleep. And then I can switch it off in general or put it on silence. The question is, how can we adapt all what's ongoing in our hospitals to go back to these real values that you highlighted about the true relationship that should exist between a doctor, a caregiver, a doctor and his patient or her patient?
So I think that there are several layers to the answer. First, I think we need to find out whether the younger generation, the young hematologists, agrees with this assessment. It's clear that we all are in awe of Hippocrates and how he practiced medicine in the old Greece, but it's also clear that we don't practice like he did, even though it was probably wonderful with the means that was available at the time. So before doing anything, I think that it would behoove us to have some sort of a working committee in a society like the International Academy for Clinical Hematology, consisting of the old folks and the younger generation, to define whether this is a problem that is high on the priority list for the younger generation. If not, I think we'll have to accept that and say, well, it was nice when it was there, but life goes on and patients get cured, but it will not be the same as when we practiced. If the answer is yes, we do want to do something about that. We do want some of the patient-physician relationship that you are describing. Then I think we can start talking about, with input from the younger generation, how we can join forces to try and chip into the time that has pretty much been taken away for us to do so. So I don't think we necessarily need to give the answers today, because I think we have to have the younger generation part of doing so, and only if they want to do so. And I'm not sure they do. And if they do, then we need to have a working group and get to work.
Fantastic. So Didier, what do you think? Any
Yeah,
thought?
I would first. It was a magnificent talk and very meaningful. The way we can learn something. I would start by making a small comment. You said in one of the last slides that it's important. The learning from the masters is important, and I would just underline that one of the initiatives from the academy on the shoulder of the giant is clearly in this line, because it's to try to bring the words of people who have made medicine to a large amount of people. So it was just a comment, but I totally agree with you. I was wondering if...
Didier, let me explain, because maybe not all the audience is familiar with what we Didier alluding to, is that the International Academy for Clinical Hematology has launched a new initiative almost 2 years ago called Standing on the Shoulders of the Giants. And this is about asking the founders of clinical hematology, the modern clinical hematology, people like Dr. Rainer Storb, Dr. Bob Kide, Dr. Kanti Rai, to give us a history and how they ended up with developing this conditioning regimen, etc. Because my feeling today, and that was the idea behind it, is that maybe the younger generation is missing this part of history. And someone said, you would rather need to understand history if you want to improve the future. So I'll stop here, but I wanted to clarify this and give you back the microphone, Didier.
Thank you, Mohammed. My first question would be, cellular therapy has a reputation to be a high-tech specialty. Do you think what you have described is only restricted to this kind of specialties, or is really for all the aspects of medicine?
I wouldn't know because my world has been cell therapy for so long, but I suspect that it goes way beyond cell therapy because it goes to the very central part of being a physician or provider, which has not changed since the time of Hippocrates, which is that the relationship between you and your patient, the fact that you show the patient that you understand what he or she is going through, and the patient trusts you. That is something that, if not facilitating healing, which my bias is that it does, but studies may not bear that out because of the nature of the studies disturbing that, that has not changed since Hippocrates or Paracelsus or through time. But I do see the computerization where providers are going to use a lot of time on the computer. They go into the patient, the nurse has already screened them. There's a computer screen with lots of things in diagnosis. And they spend 5 minutes mostly discussing whether the diagnosis is correct or the medication is at the right dose currently, but nothing about what's going on in your life. How does the fact that you went through a transplant or CAR T, how's that affecting? How is your sexual function? Et cetera, et cetera. Those are the things that are getting lost between a physician and patient. There are social workers, there are nurses who may try to pick that up, but they are also being bogged down by computers. And so I do think we are at a crossroad where we may be looking at losing something that has been essential for the practice of medicine since Hippocrates.
Thank you, Finn. I think probably we won't have the final answer or the solutions today, but definitely you are emphasizing the fact that we need to tackle this. And one of the issues you have raised, and I believe this is crucial, is that we need to have a dialogue with also the younger generation who are really adopters of these technologies. And for instance, we have a very wise comment from Dr. Esra Gulduran from Turkey. She is a young rising star hematologist doing an amazing, great job. I know her, and she is very loyal to the ICH activities. Saying that it's a long comment, but if I summarize it, that it's even more complicated in cultures where not only the patient has access to immediately to his data, to the information, to the lab data, but when the family involvement, the environment, and it makes it even more confusing, and that is maybe disrupting this so-called personal confidential relationship that a physician should have with his or her patient. And the next comment, which is maybe a question to both of you, Didier and Finn, is about the advent of artificial intelligence. So could we, for instance, envision at some point that artificial intelligence can facilitate our life, and then we can get back a little bit more time again to what we used to do historically and dedicate more time to the patient because we have something, a sort of a robo doing some job for us. I don't know if it is clear, but I'm sure you can sense where I want to go.
So I can tackle that, if it's okay with Didier first, by saying that be careful of what is being promised because it sounds very much like the promise of implementing the EHR. It will save you time. You will be more effective with using less time resources, and you will be able to spend more time with your patients. The opposite happened. My concern is that even though AI may have the potential for doing that, that's not what's going to happen. What's going to happen is that the force of physicians is going to be cut and reduced because artificial intelligence can do a lot of what they are doing. And the remaining people, the remaining physicians, are going to check, make spot checks or other checks on the artificial intelligence to make sure that it is running according to plans. That's my prediction. And that dire prediction is based on hard-learned experience, especially from the implementation of the EHR, which accomplished the exact opposite of what was promised and for what reason it was approved by hospitals and politicians.
Didier, are you on the same line?
I do. I totally agree with Finn, and I'm thinking to one of the slides he have shown where he, on what aspect he showed what have been the promises and what are the results. So, and we have to be very careful with that. Nevertheless, and your question I think was really important. Electronic record are as a step, probably a first step. Artificial intelligence, we have now access to the first generation. There will be other generation of artificial intelligence. And one of the conclusion and the issue related to electronic record is the amount of information we get. And it's not always meaningful. And we can have the hope that the second or third generation of artificial intelligence may help us to find the real meaningful information to help the patient. What do you think about that?
Well, I can summarize it, what you're alluding to, because we're confronted to this problem every day with clinical research, is that definitely the more is not the better. Because, for instance, in clinical research, we have seen the burden of paperwork, the burden of reporting, the burden of having all kind of electronic platforms and vendors to do this and this. And I'm not aware of any data showing me that this has improved the outcome of a single patient. So it's probably, if I want to be nasty to say, it's mainly a billing exercise. But that's another story. Finn, what do you think?
I think that we are way behind in having input on where AI and computerization is going. Up until this point, it has been completely directed by software engineers and people with an MD degree, but not clinical MDs. They went into the computer part for a reason. They probably weren't good doctors, and that's fine. That's always been like that. I think if we as clinicians wants to have input, we better get our act together. And I think that that will take on high levels in the various medical societies, including in the oncology areas, working groups who did the same thing as happened when the JC and FACT was created. There was a huge problem. People died because of mistakes that went uncontrolled, which was the impetus for creating FACT and JC. And eventually that got under control. I think that we as clinicians will have to use some time, but if we share it out to enough people, we may be able to have some power and some influence on the non-clinical doctors and software engineers who are currently dragging us around by our nose.
So can I be a little bit provocative? Because my role as a moderator is to be fair and balanced. But okay, we're criticizing artificial intelligence. But if you have data with artificial intelligence, telling me that artificial intelligence can read a lung CT scan and make the right diagnosis very quickly, immediately, in the middle of the night, much better than my beloved radiologist. I have a lot of respect to them and I'm very grateful. Why say no? If artificial intelligence can, have a photo of a skin lesion, and I think it has been demonstrated when you suspect a melanoma, and can do better than, a friend dermatologist. So how do we find the right balance?
I can answer that.
Please.
Yes. We already use artificial intelligence in those areas with great benefit to both, in particular, our patient and to ourselves. I think that's great. However, what I'm trying to impress with this talk, and where I think we have to draw the line, is that artificial intelligence should not communicate with a patient in writing or with a construct imitated voice. That is where we are headed, but that is where the risk of losing what we have had for centuries, I think, is the highest. We can do both, but the AI and computerization should not replace the touching, the empathy, the having the patient being comforted no matter where they are in their terrible diseases, because that is where we as humans can do something machines can't do. And I think that fact is being lost in the direction we are currently going.
Didier?
Yes, I would say, and I agree again with you, but I would say something a little bit different. I mean, there have always been real clinicians in the world of medicine, and some people were not. And I would say that personally, in young doctors, I trust, because they will find the way to take care of the patient. And I do think that's very important. But we have to help them, and to help them by this kind of discussion, and to warn them of the danger of the evolution.
So can I absolutely share your comment, Didier, and maybe I'm an eternal optimist, and I believe that the younger generation who will potentially treat us will do well. And actually, we have a very nice and straightforward comment from Professor Gosta Garten, who is a true giant in the field. And Gosta, we are very proud and honored having someone like yourself following the ICH activity. And his comment is very simple. Maybe we can start by removing the computer from the room where we meet the patient. And actually, this is not unrealistic, believe it or not. On a personal level, when I do my clinic every Wednesday, actually, I prepare it few days in advance by asking my secretary to print the reports. I have to read them. Then during the consultation, I don't have any screen, and I look and discuss with the patient. And I don't feel that I'm wasting more time or I'm seeing less patient. What do you think? I mean, Gosta raised this, and I believe he's probably right.
I do the same thing than you, Mohammed.
And
of course, I learned it from you. You are my master and my mentor. So this is where I learned it.
You can say what you want, but it does take more times. For my team, for my physicians, I would like to give 60 minutes preparation time for a consult. I was allowed 30 to give 30 minutes. What I personally did was going through all the notes, as well as all the social workers' notes and the nurses' notes. And that does take time. I then went into the patient with no notes and no computer. And if there was a dog name in one of the social name, I would know, I would tell the patient, so how is Fido doing? I know you've had some problems with disease. I wouldn't say that, but you get the gist. That when a patient you meet for the first time understands that you've taken the time and the interest in knowing their story, knowing who they are, you have already put down the foundation for the trust you will need to make them compliant and to increase the cure rate. As I said in the talk, I don't know whether the cure rate is increased or not, because the data is all over the place when that has been studied, but the study itself may have impacted that outcome. But it's intuitive to me to believe that a patient who trusts you and who feel you truly care about them, that you spent the time that is required, whether it is within the 15, 30, 45-minute slot, that if you do that, they trust you. If nothing else, they are more comforted, but maybe even have an increased chance of cure because of that.
Well, thank you very much, Dr. Petersen. This was a fantastic, positive conclusion. I like it a lot. I think we should remain optimistic. The good news is that we're clearly more and more identifying this problem. And I personally believe it's always good to identify and discuss a problem, even if you can't find immediately the solution. But as also Professor Blaise mentioned, we can still be optimistic that the younger generation will find the right balance between the increased use of technologies and the domination, I would say, of IT versus this mandatory human relationship that and dialogues, very, very intimate dialogue that needs to happen between a patient and a physician. And it's work in progress. You have made a super call for action, Dr. Petersen, and at the ICH, you can count on us to bring the voice of our patient, because this is about our patient. Because what we are talking about here is about defending and advocating for the patient. And I've never met a patient who said, oh, I don't want to spend some time with my doctor, or I dislike, chatting with my doctor about this and this. Any final comment, Didier?
No, no. I totally. I think it's an important topic, and basically, as you said, patients are in the middle of everything, and we have really to continue to be the advocate of these patients.
And I don't think it's not the older generation against the younger generation. I think we all agree that if the younger generation had the time, was given the time, and that they would be just as we were, but they are not. They are required by law, by hospital rules, by whatever, to finish tasks on the computer that makes it impossible to do it all. If we have to be antagonistic against anyone, it's going to be those who let this dog loose, meaning the politicians and the hospitals. And we need to counter that. We need to counter the colleagues who are not clinicians, who tell the software engineers to direct us through their programming to do things they know very little about. That is my goal.
Thank you very much. We are now almost 10 minutes past the hour. I hope you have enjoyed this webinar brought to you by the International Academy for Clinical Hematology. We do have a lot of activities every week. But in the meantime, wherever you are, please stay safe and keep well. Thank you very much.
Bye.